Hello, and welcome to the June 22nd Virginia Opioid Abatement Authority Abatement Academy. My name is Jennifer Nelson, Virginia Institute of Government Assistant Director for Membership and Engagement. The Virginia Institute of Government is the leadership development and community engagement arm of the Weldon Cooper Center for Public Service at the University of Virginia. Through our research, leadership development programs, and local government engagement initiatives, we continue to work toward our vision of good governance, equity, and resilience in every Virginia community. VIG offers leadership development through SEI and LEAD, local government equity clinics, certification for treasurers and commissioners of the revenue, and customized training programs. State agencies and local governments can access a range of consultation and support services to build more resilient organizations. We have a team of seasoned public sector leaders and subject matter experts ready and available to facilitate boards of supervisors, city and town councils, leadership teams, strategic planning retreats, and other related events. Today, VIG is glad to partner with the Opioid Abatement Authority for the Abatement Academy series, presented every second and fourth Thursday through 2023. A few housekeeping notes. This session will be recorded and posted on the Weldon Cooper Center for Public Services YouTube channel soon. If you have any questions, please type them in the chat. I will ask them for you at the end. Thanks again for taking the time to join us for this Abatement Academy session. Now I am happy to turn things over to Tony McDowell, the Authority's Executive Director. Tony?
Thanks, Jennifer, and good morning, everyone. Thank you for joining us. I have the distinct pleasure of introducing our guest speakers this morning, and I'd like to start with Dr. Alan Yee. Dr. Yee is the Operational Medical Director for the Chesterfield County Fire and EMS Department, where he served since 2004. He graduated from medical school at Stony Brook University in 1997 and completed an emergency medicine residency at the University of Buffalo. He's board certified in both emergency medicine as well as emergency medical services. When he's not at work in Chesterfield County, he works clinical shifts at the VCU Medical Center Emergency Department. Lieutenant David Bigelow is a 15-year veteran of Chesterfield Fire and EMS and has been the Mobile Integrated Healthcare Program Manager there for 2 years. His team includes a peer recovery specialist who follows up after 911 calls for addiction-related issues to assist people in their recovery process and to provide harm reduction services. Battalion Chief Justin Adams has been a career firefighter with Chesterfield County Fire and EMS since 2004 and has served in emergency operations and in the training and education division. Since 2019, Chief Adams has been the agency's Director of Emergency Medical Services. We're very excited to have our friends from Chesterfield joining us today. They have a really amazing program they put into place that's saving lives, and they have the data to show it. We asked them to volunteer some of their time and for the opportunity to present to you today. So with no further ado, I'll turn it over to our guest speakers. Thank you.
Thank you, Chief McDowell. Jennifer, can everybody see the screen that we're sharing?
Yes, we can.
All right, well, quickly before I turn this over to our main presenters, I just kind of wanted to give everybody a quick overview of Chesterfield County as a whole. So Chesterfield Fire and EMS, we are an all hazards organization located in the Richmond metro area. We deliver fire and EMS services through 23 fire and rescue stations, which encompasses a geographic landmass of over 446 square miles. Last year, we ran over 52,000 calls annually. And beginning January the 1st of 2024, we will have a career workforce of over 600 people. Our fire and EMS system is also augmented by 4 volunteer rescue squads and also with the addition of 183 operational volunteers. As Jennifer stated in her opening comments, most recently, UVA's Weldon Cooper study has cited Chesterfield County as the fastest growing population in the Commonwealth, growing faster than Loudoun and Fairfax combined, adding over 17,000 new residents annually. And with that, I'll turn the presentation over to your main presenters, Dr. Alan Yee and Lieutenant Dave Bigelow, and I hope that you all enjoy.
So welcome everybody to this. We're actually very proud of our program and our efforts that we've gone under this in this endeavor. But we wanted to kind of demonstrate how we went to this journey, and we started with how we looked at data. Everyone's probably seen these slides from 2022. It shows the number of fatalities among all genders from 99 to 2001. You could see the sharp increase that happened around 2015, 2016. If you look at the opioids, you could see that where the red arrow is, that nationally we saw a tremendous rise starting in 15, but really in 19, the rate of climb from synthetic opioids, other than methadone, was incredible. Majority of this is fentanyl, and there's probably a little bit of that fentanyl mixed into the synthetics. When we looked at death from any opioid among all ages, again, we started looking at efforts around 2017. 47,000 deaths per year. That's 5.4 deaths per hour. Nobody can argue that this is not a pandemic, an epidemic. It's a true crisis. If you looked at, that was the national data. When we looked at it from the state, this is 22, 23 data that was released. If you look from 2007 to 2022, the deaths, if you look at the opioid death rates, Virginia was no different. We saw a climb, albeit a little bit later. Look at 2018, 2019. That's when we started seeing a huge rise. So we went down to regional data, and we're like, all right, so what did our region look like, and how did we compare? The red line is Chesterfield County, and you could see that, we saw the rise really started in 2015, and then and on. There's other jurisdictions that did see a sharper rise than we did. That's just total deaths. And we looked at death rates by locality. The black line is Virginia, and the red line is Chesterfield County. We were for the longest time sitting below the state death rate, but in 2015 we really started to climb at a rate that we really did not appreciate. We actually had in certain months in the last couple of years, we were actually one of the higher fatality numbers per county compared to our rest of the state. So we said, all right, regional data, we're looked at Chesterfield County data. So we started looking at this in like I said, 2017. We partnered with SAFE, and SAFE is an organization that looked at addiction especially in the younger population back in 2017. They did a survey of high school students, and I was astonished at the results. 68% of 12th graders have tried alcohol. 37% of 12th graders drank in the last month. The 10th graders, a quarter of the 10th graders drank in the last month. To me, being someone who doesn't drink at all and can't metabolize alcohol, this was difficult to understand. Then, among other high school students, we said 35% drank some alcohol, 21% binge drinking, and then 22%, and this is one of my pet peeves, is rode somebody in a car who's been drinking. All right, so when we saw a good number of alcohol-related fatalities in the adolescents. But in terms of marijuana use, whether you believe it or not, whether this is a bridge a drug, we did query our students in 2017. 35% of 12th graders smoked pot in the past year. 20% smoked in the last 30 days of 12th graders. 16% of 10th graders smoked pot in the last 10 days. In the last 30 days. 6% of the 12th graders said they use marijuana every day, and over 3/4 of 12th graders said it would be very easy to get marijuana. Then we started looking at other things. So 44% of students know a classmate who sells drugs, and then when they asked what kind of drugs they can get, 24% said they can get prescription drugs. 9% said they can get cocaine easily, and 7% could get ecstasy. So we knew we had a problem. So we started looking at other data that we had, especially with 911 calls for service, because that was right at our fingertip. This map shows in 2017 our calls for service for Narcan, what we would consider overdoses, knowing that just because someone gave Narcan doesn't mean it's an overdose. If you look at the literature that's out there, the science, just because we're relatively evidence-based, about 2/3 of the Narcan administration would be associated with true opioid overdoses. So this 2017, here, excuse us 1 second. Move that thing over. All right. It should be 8, the next year, the year after that. You can see how it's growing. That's 2017. All right. So what's really driving the increase on our overdoses? We knew that there was a change in drug supply. The synthetics were out there. Fentanyl is in everything, leading to more and more deaths. And more recently, especially in the Northeast of the United States, we're seeing mixed in with other drugs, such as xylazine, an alpha-2 agonist. We know that during the pandemic, we started seeing isolation, the lack of connection. We saw an increased use of drug use, increased suicides, increased deaths altogether. We also know that because of the pandemic, we lost several treatment options and other points of access. So we knew that there was a problem. Then the question is, what do we do next? So we knew we had it, when using fire department data, we knew we had an issue with the fatalities. We knew the rates were climbing, but as a county, we all looked at it, what each department could do, and how could we each impact it. The way we approach it in the fire service, we looked at the overdoses because it represented a near miss. The fatality was the miss, and the actual overdose was the near miss. So we looked at the overdose as an opportunity to intervene while we could, because at time when they overdose, they were much more prone to accepting services. So as close as we can get ourselves to time zero, the better. So what do? Do we just use the good idea fairy? And I've been well known to do this, throwing ideas out there, seeing what sticks, and just, the good news of this, we could be relatively very creative. The downside is we could spin our wheels. So we call that the good idea fairy. And I am well known for being one of the biggest good idea fairies. But there's something called evidence-based practice, evidence-based medicine. So could we use EBM, evidence-based medicine, to drive what we do? So evidence-based medicine is a systemic process primarily aimed at improving care of patients. It's really a Venn diagram of 3 different circles: clinical judgment, the evidence, and then patient values and preferences. Where it intersects is the evidence-based medicine, evidence-based practice. We know that there's levels of evidence out there, and you go from 1A to 5. 5 is just a bunch of people in a room saying, like, heck, this is a wonderful idea. It's basic consensus based. Unfortunately, when you use that, it's the easiest to implement, but it has the least amount of scientific evidence behind it. And it goes, it goes like, you can actually go down rabbit holes, unfortunately, pretty quickly. The best evidence is what classified 1A, systemic review. These are randomized controlled studies. Then there's 1B, where it's a randomized control study, but the evidence is a little less strong. Then there goes down to 2, where you do reviews, and so on, so on. The more evidence we can use in the category 1, the better. All right, there's evidence on the use of medication-assisted treatments, basically Suboxone, methadone. These MATs are associated with the highest impact in mortality. We know this. We know that, going back to 2017 and until recently, very few emergency departments were offering their services. The good news is with the removal of the X waiver now, we're seeing a lot more emergency departments give Suboxone at time 0. There's also peer specialists that we can incorporate. And we'll talk about this later, but we actually have a peer in our unit that deals with these patients, and we've been tremendously successful. The evidence on peers is not as strong. You won't see a lot of randomized controlled studies, and you won't so it won't be as good. We're also I'm also under the personal opinion that the studies are looking at the wrong thing for us. We use peers to bring people into the system. The evidence really, most of the studies that look at peers look at how well did they do to keep people in recovery, not just get them into recovery. So they're two separate things. So the evidence may be looking at the wrong thing. And maybe in the future, they'll do much more larger studies that show what the true benefit of peers. Naloxone, we've been, EMS has been using naloxone for decades. We all know naloxone reverses opiate overdoses. It's been in clinical use for decades, like I said. Now, could we use take-home naloxone? The evidence for that is sparse at best, but we know that it gives the ability to save a life and gives us the ability to now then engage the patient in other services. So I think that there's a growing body of literature for the benefits of take-home Narcan. The reality is Narcan harmful? It's unlikely to be very harmful. Can you put sense of people into withdrawal? With IV Narcan, absolutely. In intranasal Narcan, much less likely, but still possible. But that's another opportunity for us to engage the consumer. There's also evidence on intensive outpatient programs versus residential versus detox centers. There's a growing body of evidence out there and looking at which one is better. Overall, they say that there's no difference in inpatient detox and residential treatment versus intensive outpatient. However, there's likely going to be subgroups that do benefit from residential services. All right, especially those that go into an environment that for example, they're homeless or they're going back to an environment where there's rampant drug use around them. Those patients, there may be some much better benefit for residential services. Otherwise, in general, the outcomes for both are about the same. There's also evidence for needle exchanges. We know that IV drug abuse is associated with HIV, hepatitis, syphilis, and the medical cost of those diseases is tremendous. So if organizations choose to do needle exchange, you really will reduce downstream healthcare costs. There's actually a relatively robust evidence on this. So we know that we actually, we had a problem, and then we had to find solutions. Turn it over to Lieutenant Bigelow.
All right, so what did we do? Let's hold on just a second here. So we looked at what are the barriers to getting people help that are dealing with addiction. Well, stigma is the big one. Not only friends, family, and society, but even from healthcare providers. So being active in this space and getting people into recovery service has broken down stigma on kind of bi-directionally. It's broken down stigma because people look at us, look at the fire department, look at Chesterfield Police Department has a peer recovery specialist through Project Recover. So they look at us, they look at public safety, and they say, hey, here's somebody that cares about what's happening to us. So it breaks down the stigma from people with substance use disorder to public safety. It also, working with peers and having peers as part of our team, And getting them out, educating other people in the department breaks down stigma the other direction too. Because we get to know people as people, people with substance use disorder, not what would historically have been thought of as addicts or drug addicts. They're people with a disease, which is what we know addiction is. So breaks down stigma both directions, which gives people a better chance of getting into recovery. So access to treatment, the thing that I like to talk about that the fire department brings to the table is access. We have access to people at a particular low point where they may be open to treatment options at a time when they would not otherwise be. We also know that after somebody overdoses, they are very likely to overdose again in the next short period of time, 24 to 48 hours. People that are discharged from the emergency department are very likely to fall victim to a fatal overdose within the following year. So having access to these people that are dealing with substance use disorder is a big thing that we bring to the table. So our goal is to get them to MAT. We know that MAT gives people about a 50% higher chance of long-term success and recovery. However, you want to define long-term success and recovery, which there's still a lot of discussion about that. Peer recovery specialists have been something that we've used ever since 2018. It is, again, as Dr. Yee said, our goal is not to manage patients long-term. Our goal is to get people engaged in treatment and then hand them over to wraparound services that are going to give them not only MAT, but access to the other long-term supports they need, job training, housing, transportation, things that are kind of beyond the scope of the fire department. Intensive outpatient, as Doc also mentioned, is a very good treatment option. It doesn't have to be residential. Matter of fact, residential treatment is often not correlated, and evidence has shown residential treatment is not necessarily correlated with higher success rates. So our goal is to get people to intensive outpatient. Occasionally that is, that does require inpatient if people are in bad situations with some of the structural components of their life. Social determinants of health obviously determine this, or obviously affect this. So things like poverty, things like, healthcare status, economic factors, silos of care. Another thing that we're very good at working across, mobile integrated healthcare. My team is, we're connectors basically across all kinds of chronic disease, addiction being one of them. So historically, the fire department in some situations may have said that that's beyond the fire department scope, not my problem, not my mission. We look at it differently. We look at it as our job is not to manage these individuals long-term, but because we have access to them, we have the opportunity to navigate them to public-private partnerships and integrate them into a recovery process. Cost of treatment is a big one. Going back to social determinants of health, a lot of the people that we interact with do come from impoverished backgrounds. They are uninsured, underinsured. And so recovery funding that the Opioid Abatement Authority has as part of the scope is huge, because when people are ready for treatment, we've got to be able to strike while the iron's hot. Again, the 911 system's well positioned to intervene because we do have access to people at a time that they may be receptive to recovery. And then EMS is well positioned to assist in mitigating the effects of and reducing social determinants of health. The American Rescue Plan Act funding that has been so instrumental to a lot of fire departments, as well as now the opioid abatement funding that's coming online, is intended to cut across all, be able to benefit people regardless of social determinants of health. And the fire department is kind of the great equalizer with that. We respond to people who have nothing. We respond to people in $1 million mansions, and we don't treat them any differently. The window of time to engage these patients in recovery is often small. So again, having access to funding knowing that MAT costs money, wraparound services, IOP, residential rehab, if that's applicable to some patients. There's a cost associated with all of these, but the cost of not having that available is oftentimes measured in people's lives. And that's what the goal of this is all trying to avoid, getting these people into recovery, getting back to their families and to the life that they're capable of living. So again, I mentioned that our mobile integrated health team treats patients with all kinds of chronic diseases. So congestive heart failure, mental illness, diabetes. We know that addiction is a disease that changes the neurochemistry of the brain, and we treat it as such. We treat it with medication, but we also understand that there are other components to it. I mentioned, job training, housing, transportation, kind of the big three right there. So MAT is not part of everybody's path, but it does give patients a much higher likelihood of being successful long-term. So engaging patients, getting them to MAT, and understand that there shouldn't be a stigma associated with MAT, because it's a medication just like a diabetic takes insulin. It's something that gives them a very much higher chance of being successful in recovery. We treat each patient like the person that they are. Again, that's a good part of having peers involved in our system, having peers involved in our BLS continuing education. We get to know people. I have become great friends with peers. I know their kids' names. We talk about baseball. We talk about all kinds of different things, and we reduce stigma when we understand that substance use disorder, a person is a person with substance use disorder. They are not their addiction or disease. Incorporation of peer recovery specialists. Again, there's been times over the past 5-6 years that we've had periods of time where we did not have a peer in place, and we followed up with patients, and myself or some of the other uniformed personnel. Hey, this is Dave with Chesterfield's MIH program. Just wanted to call. I know we were out there a couple days ago. Just wanted to make sure you were okay. Wanted to make sure you had Narcan, and it was a lot of not interested. I nothing happened. Wrong number. And then I'm thinking specifically of one of these. The peer came in. There was somebody that we had reached out to 4 or 5 times. When the peer reached out and said, "Hey, I'm a peer. I'm somebody that's in long-term recovery, and wanted to reach out to you." We were sitting down with them within 2 hours, and that person's still in recovery months later. So we are first and foremost clinicians, and we bring that to the table. But having peer recovery specialists as the opioid abatement funding, if you look through the 16-page document that outlines the scope of it, it's peers, it's peers everywhere. And as Doc had mentioned, the evidence peer recovery is still formally a fairly new field. I think that it's been around in Virginia. I think certification started in 2015, but there are studies that are just now getting going. National Institute of Drug Abuse has a number of organizations that are researching it, and so I think we'll see some of that. Hopefully, some more data validating peers the same way that MAT is validated. Widespread education and engagement of departmental personnel. We've been doing that. We just finished up 16 BLS continuing education sessions where we engaged our providers so that when they deal with somebody with addiction, they can provide a warm handoff to my team. So we know, we are a high-risk community. Every place is a high-risk community. Kind of ground zero for the fentanyl epidemic. It started in the Northeast and spread across the country. Appalachia has been particularly hard hit by Kentucky, West Virginia. So we see higher rates of addiction in communities with lack of access, higher rates of poverty, and a high disease burden. So what did we do starting off? We did a health fair screening. Narcan training, engage social services, mental health services, and then we link people to substance use disorder services. So it really does. This is one of those situations where it really does take a village. There's not one organization that's going to solve this. It takes everybody working together. And in a sense, the pandemic has escalated the crisis to where last year we lost 110,000 people, but we also are now at a point where we have funding that's coming to light to put innovative programs in place. My team is four firefighter paramedics, 1 firefighter EMT, and myself as a lieutenant and paramedic. I get a report every morning, and anytime a patient overdoses or Narcan is administered, one of our providers who has some lived experience follows up to determine the root cause of calls and implement solutions. It may be a text exchange. A lot of times, the person may not be able to, or may not be willing to engage in recovery at that moment, but hopefully it at least plants the seed, and sometimes that seed bears fruit down the line. So we work as part of a collaborative effort, obviously with multiple organizations, the CSB, County PD, all kinds of other organizations. Anytime Narcan is administered in the field or call is coded as an overdose, we follow up. We will work with social services to get patients qualified to Medicaid, and funding has obviously been something that's been paramount. There's been some changes with some things with SOAR grant funding, and hopefully I know the Abatement Authority just approved some money for outreach specialists, peer recovery specialists, and very importantly, wraparound services, which will give us the opportunity to do some really good things and hopefully save a lot of lives. This is just how our program works. Again, we get the referrals. Our goal is to connect with them and then get them to recovery. So the number of patients for referrals has skyrocketed. Last year, out of our 578 referrals, total of 219 of them were for substance use disorder. Rates of uninsured and underinsured. Need for resources is significant. About 75% of those who were transported for substance use related disorders were uninsured, and the ones who were transported were uninsured, and a total of 83.5% were uninsured. So there are, for the ones that are transported, the X waiver going away has hopefully lowered some barriers to emergency departments, starting people on Suboxone. So there are different initiatives like that going on as well. Small window of time to engage these individuals, and again, the allocation of resources for recovery funding is huge for us and for other localities, so that we are able to take advantage of the small window of time that people are often receptive. And I will turn it back over to Dr. Yee now.
So here's some of our data from our program. If you looked at this graph, when we started out in 2018, we had a tremendous number of our patients accepting services. So we got our referrals mainly out of the 911 service side at first, but we also take referrals from emergency departments, other county departments, a friend of a friend who heard about us and sends an email or a text message. So our population has kind of shifted over the years. But when we first started in 18, we were very successful in contacting people, relative to where we are right now. I mean, over about a third of our patients would we be able to contact. In 2021, we dropped like a rock, probably because of COVID. And we're down to 10%. And right now we're floating in the 15-16% range of we're at, the patients are actually saying, yes, I want to help, that I want help. In fact, when we started in 18, it used to be, we were able to contact about 2/3 of our patients on the 911 side. We actually had legitimate phone numbers. And out of those, we get a third of them would say, yes, I want help. Now we're not batting as good. I'm not sure why this is happening. Some of it is because we're getting referrals from other sources. Some of it is maybe something has shifted in operations and we're not getting legitimate phone numbers. We've also looked at how long does it take us to get to MAT? If MAT really gets us, a significant drop in mortality, what can we do? We got to touch these people at time zero. So how long does it take us to actually get an MIH, a mobile integrated healthcare provider or a peer in front of an individual? In 2018, when we started, it took us 7 days from the time they overdosed to the time we actually saw them. But in 2021, things shifted, and we were actually as high as 11 days to get to the patient's home or wherever, just to make contact. And we know we've lost the initiative because we're true believers in that the best time to do it, to get in touch with these patients, is time zero. The earlier, the better. We learned that from the trauma data, from in some of the projects they looking at alcohol use in motor vehicle accidents. The best time to intervene is time zero. So we knew that 11 days was not acceptable. We're now back down, to the efforts of the group. We're actually back down to 2 days now. So kudos to the group. We also believe in leave behind Narcan. I'll turn that over to Lieutenant Bigelow.
Yeah, so we started leaving Narcan behind after 911 calls where our providers, if they administer Narcan or run an overdose, we have a Narcan supply kit, which has Narcan and then a recovery resource card. And then importantly, we want our providers to do everything they can to facilitate a warm handoff. Anybody who is not doing this currently, I would encourage you to do so. Ours is a partnership with the Virginia Department of Health as a harm reduction partner. So that is available to government agencies, to nonprofits at no cost. We want to get Narcan out there. And again, we understand that addiction's a disease and we're treating it similarly to other diseases. So our Leave Behind Narcan program started in 2021. That year we left behind, started in October 2021. So we left behind just shy of 40 kits. 2022, we left behind about 150, and then 2023 were a little over 100. So from a breaking down stigma standpoint, this has also been good because our providers understand that, and we've had conversations and we've talked about it in Con Ed, historically, not necessarily with us, but other places have said, well, are we enabling people by giving them Narcan? Well, no, we're not enabling them. We're enabling them to not die from an overdose so that they can then get into recovery. And we know that people that we engage in harm reduction are typically about 5 times more likely to eventually want to pursue a path of recovery. So Leave Behind Narcan, there is not a tremendous expense to the locality. Again, we get it free from VDH. If anybody wants to contact me, I will be more than happy to share anything that we've got about how to get set up on that. And then Bruce Taylor with VDH was great with it also.
So when we looked at, how successful were we in dealing with the fatalities and stuff like that, because that's the end of the day is, what is the juice worth the squeeze? Did we produce results? So when we looked at, again, we went back to look at, you saw part of this graph before up to 2017 but here's our fatality rates. Look at 2020 and to 21 to 22. We saw a sharp drop in the red line, that's Chesterfield County, on decreases. Yes, some other counties, you see the yellowish golden line, that shows that locality had a tremendous rise. The green line and the red line, we all saw some decreases, but you can see Chesterfield County saw a marked decrease in deaths. When we looked at rates, we also saw a decrease in death rate. If you look at the black line is the death rate in Virginia. The red is Chesterfield County. You see, and the other ones are other localities near us. One locality is continuing to see a huge rise in the death rates, but Chesterfield County has the largest decrease in death rates among all of our locality partners. We also looked at, if, we believe that, like I said previously, that we believe in MAT has the greatest impact, but, how can we get them to MAT? When we started in 18, it took us over 20 something days, 3 weeks to get somebody to MAT. In 2021, we were able to decrease that up into that 6-7 day range. And even last year, we were above 10 days. So if it took us that long to get somebody to MAT, I think we've lost our edge. We've lost the fight, because the best time to do it is time 0. We know that the emergency departments are starting to do it. So hopefully in 2023, we will be able to make an improvement. But is that enough? So should we do pre-hospital Suboxone? So this is a future initiative. We should be by the end of this month, which is in just a few days, in a week, hopefully have this up and running. So initially, we will be doing this. So our plan right now is we're going to use our mobile integrated healthcare providers / peers, and engage the patient, and then we're going to do a telehealth visit with the prescriber, i.e. me, and we're going to write a prescription for Suboxone, and we're going to induce them at home with Suboxone. We're going to give them Toradol for the aches. We're going to give them Zofran for the nausea and vomiting. Just trying to give it kind of that cocktail to make them feel better. We'll likely then transition to the MIH provider, then carrying Suboxone, administering it at the bedside through a protocol. Our thought is maybe we will be able to actually do this through the 911 side, and so that it will be available on every ambulance. We do know in the literature, although it's not a randomized control study, there are several EMS organizations across the country that do this. The most bang for your buck is probably through your mobile integrated healthcare personnel or a dedicated person. When you roll it out to the 911 units, your utility, your use starts to drop down a little bit. So we are debating that, but we will be starting some sort of pre-Suboxone probably by end of next week. Another initiative we want is drop-off centers, right? In terms of the emergency departments. We know that the hospitals have designated stroke centers, STEMI centers, trauma centers. If you look at Joint Commission, there's hip centers of excellence for hip surgery. Why can't we just partner with some EDs, especially ones that have good throughput, so that we get people in and out? For example, utilizing some of our freestanding emergency departments. Can we partner with them and says, all right, we'll take our overdoses to you. You start them on Suboxone at time 0. Whether you write a script or not for the Suboxone is up to you, up to them. But we'll pick. You call us. We'll pick up the patient, and then continue it, and we'll link them for wraparound services. We'll continue the Suboxone short term for maybe a week until they can get into services. So this way, from beginning to end, from overdose, to the time, a couple weeks later, that somebody will be working with them, holding their hands virtually, to get them support they need to in their journey to recovery. So in summary, we know addiction's a massive public health crisis. No ifs, ands, or buts. We also know that addiction is a disease, and that's the first step that the public safety, that our partners need to recognize that they're not addicts. They're people. They just happen to have disease, like Lieutenant Bigelow said. Just like diabetics have a lack of insulin, type 1 diabetics have lack of insulin. There's some biochemistry changes in patients with addiction, and we have to help them through their journey. Data and evidence-based practices can really prioritize what we do and reduce wasteful spending. Making strides on behalf of those struggling with addiction is going to take a complete multidisciplinary approach with many organizations working together to reach people where they are. If we think that people will come to us, I think we're mistaken. We have to go to them and we have to break down the barriers. We have to take the Mayo Clinic approach where you sit down and every doctor comes to you and to get your job done, get the job done instead of the patient going from one visit to another. Despite not being a traditional core function, many departments are positioned to be a key contributor in helping those dealing with addiction get recovery resources. We can't have that. It's not there's no margin. It's not my mission. That kind of attitude. These are individuals. These are lives that we're saving. You can't put dollar amounts on it. So we all need to partner together and forget about these silos, work together and create a safety net so these patients get what they need. And here's our contact information. We're happy to answer any questions.
Thank you. Thank you so much, Lieutenant Bigelow, Dr. Yee, and Battalion Chief Adams for sharing the story of Chesterfield County's success in connecting people to from overdose to treatment. And I'm glad that the Opioid Abatement Authority has brought you in to share your story. We have a few questions already, but please, if you have any more comments or questions, add them to the chat. I'll ask them for you. So here we have one question. It was covered in your slides, but if you could answer, how quickly do providers follow up on post-overdose?
Sure. So we get a report every morning. Our goal is within 24 hours. So if it's later on at night, then it may be faster than that, but our goal is within 24 hours.
Obviously, it's a work in progress.
Right.
I mean, we also believe in making sure our providers stay healthy. So we do have a gap on weekends. We don't really provide weekend coverage. So that's why some of our data will never get to 24 hours. But we're going to get as close to that possible as we can.
Great. So quick. Does your fire and EMS report the ODs on the OD map to look for spikes in locations?
So we do not. We don't report to OD maps. Chesterfield Police Department does report to OD maps. And then we are also part of the Regional Spike Alert Initiative. So our threshold is set to 4. So anytime there are 4 overdoses within a 24-hour period, yes, we do get the, it's not as a result of our image trend reporting, but we are part of the regional initiative for spike alerts.
We actually engaged with OD maps early on when they approached us. And I think back when we first started this, I think there were issues with us reporting locations to OD maps because of privacy concerns. I think those have mostly been resolved. My understanding is there's a large state effort now to map all of EMS's overdoses onto OD maps. So we as an individual organization don't have to do it. The state is actually going to do it for us. So for those who are not aware, we're required by regulations to finish a patient care report within 12 hours of dropping off the patient. So that data goes off to the state, and then theoretically it can get uploaded to OD maps right after that.
Great. Here's a question. Where is the data around death rate from opioids per locality from? Is this information any locality can access?
It is. It's on the OCME website. The data usually comes out the last day of April. It was a few days late this year, and it's considered provisional at that point because there is still reporting at the end of the year that still to take place. Anybody that is interested, FAACT is a data program with I think it's the Virginia Department of Justice. I'm not sure, but FACT provides monthly reports. They're real good. Anybody can get those set up. But we use the Virginia Crime Lab statistics, and then the overdose fatality data is from the Chief Medical Examiner's office.
Thank you. Are you going to be billing for your telehealth visits for Suboxone initiatives?
We are not. The department has taken the stance that we're here to serve the citizens and residents, visitors of our county, and it's part of what we do. You know, now with that said, is we do bill for service for the transports, but we won't be billing for telehealth.
Very good. Have you had any problems with getting Suboxone to dispense?
We are in the process of working through those details right now, because of Board of Pharmacy rules and regulations, and the controlled substance registrations. You know, we're going to use prescriptions at first, and we'll be modeling our protocols that mirror some of our community partners that do this as an outpatient.
Very good. Those are all the questions we've received so far. Okay, I was going to ask for one more round. Here we are. Are you able to target OD hotspots in the community and dispense naloxone in interested individuals in those areas, not just those affected by the patient, as part of community events?
Absolutely. Absolutely. So we're not the only county entity that delivers Narcan. We partner with the other ones, and we're more than happy to go to events and leverage our branding, our logos, to reach people, just like we leverage their expertise sometimes to reach other populations. So we partner all the time to do initiatives such as that. You know, we give our Narcan out. It doesn't have to be on an overdose call. I mean, our folks are free to give it on. They run a person that has a heart attack, and they notice that the patient's, you know, they say they use heroin every day. They're free to give it to the patient or their loved ones. We also know that hospitals are now doing take-home Narcan. So they're getting prescribed Narcan, you know, before they leave from overdose. So the more Narcan we flood the community with, the better it is for harm reduction.
Oh, that's fantastic. Ellen writes, one of the challenges we have in Fairfax with our post-overdose follow-up is reaching people who don't have a phone number or who we can't reach via phone, the phone number we have on file for them. If you have similar challenges, what strategies do you use to work at?
We do have similar challenges, and we've gone to other states and talked to it's a common problem across the board, because oftentimes we're interacting with people where there is, you know, there's stigma, there's people who don't want to be found. So yes, absolutely. Just as an aside, Ellen, we actually came up and talked to the port program a few months ago, and you guys are doing some great work up there. But yeah, what you're experiencing is, I think, common to not only ourselves, but also to, you know, just in this field across the country. I think some places are starting to do time-zero Narcan. So I think engaging people from right off the bat, where, you know, Contra Costa, California is administering Narcan right after waking people up. Administering Suboxone right after waking people up from overdoses. So I think engaging people at time-zero and getting them on the first steps down that road to recovery will do some do some good to alleviate that. But I don't think you're ever going to get rid of that. I think that's kind of the nature of the individuals and the situation that we're dealing with them in.
Yeah, I mean, if you look at Casa Contra data, it's impressive, but their transport rates are like 90-something% of overdoses gets transported to the hospital, where the hospital gets some better identifiers. I mean, if you looked at other systems, you know, our transport rates are going to be in the 60% range. 60% of the overdose will actually be transported. 40% are going to refuse. One other trick that we learned a couple of years ago is to look at other data sets, right? You know, just don't look at what our folks try to capture in the ambulance. We can actually reach out to the PD side or our emergency dispatch side. What phone numbers do they have, and utilize that? So going across silos, breaking down those barriers, and trying to find contact information from our other partners.
That's great.
Yeah, and I think increasing outreach is going to be another key to it, so that if we can increase the the willingness of somebody to engage with us. I think that will do a lot to to maybe make them more likely to pick up the phone or say, hey, let's meet for a cup of coffee, because I want to talk about, what a better path for me might be. So access and outreach, I think, is what it boils down to. But
And reducing stigma, right?
reducing stigma, right?
So our folks are here to help. We're not we're not here to disparage them or saying like they're lower class citizens, that we recognize it's a disease, that we're here to help them, and that we're part of a solution if they choose to engage it.
Do you coordinate with peers embedded in the EDs?
I think that there's in our area, there's less peers embedded in the EDs than in other areas. I think we're just starting to see them. So we're happy to partner with them once they're in place. But the bottom line is we'll partner with any peer, but the EDs don't use them as much as what they can.
Now, I will say, if I can add to what Dr. Yee said, Project Recover, which started here 2 years ago, and we've got a peer recovery specialist who ours is embedded with Chesterfield Police Department. They have a number of peers throughout the region, one with Richmond Ambulance. They do have one in Hanover that is dedicated in large part to Bon Secours hospitals. That's a fairly recent development. So I know that there is a big push to get peers in the emergency department, and I think that's great. I mean, the more people we can put in positions to get people to be more receptive to recovery, including the ED. I know in the scope of the OAA funding, maternal fetal medicine, with public safety, I think, the more peers, I think the better.
That's great. I don't have any more questions just yet, but I'm going to stall to see if there are any more coming. I want to thank the representatives from Opioid Abatement Authority for their time, for setting this up. And Tony, are there any last comments you want to make before we sign off?
Yes, ma'am. Thank you. Again, just thanks to our friends from Chesterfield for putting on a really tremendous program. I hope that the participants in the webinar were able to take some information away. If nothing else, you've got their contact information. Just a reminder, this was recorded, and as soon as the recording has been edited and ready for display, it'll be updated to the OAA's website. We have a tab on our website for the Abatement Academy, so you just navigate to voaa.us, and maybe Jennifer can throw that in the chat real quick, and then click on Abatement Academy, and you can see this and all the other sessions that have been completed. One other note is that Chesterfield County, in partnership with Powhatan County, the city of Colonial Heights, and the city of Petersburg, submitted a request to the OAA for grant funding that would expand this program, the program you just heard about, to those other jurisdictions, to Powhatan County, to Colonial Heights, and to Petersburg. Our grants committee has recommended that grant be funded, and the issue will be taken up by the full board tomorrow afternoon. And so if all goes as expected, this program is actually going to expand beyond just the borders of Chesterfield into those neighboring localities. And so again, as Dr. Yee and the others mentioned, you have a great opportunity to work with the Opioid Abatement Authority to either create or expand these kinds of programs in your communities. And we want to be part of that solution to help you make it happen. And so thanks again to everyone. And feel free to reach out to us with any questions or comments.
Thanks, guys.
Thank you.